talk by just thanking sir that whatever we are, it's all because of you, sir. Whatever guidance and blessings you have provided, that's only bringing the bread to our tables.
I request our chairperson to kindly introduce our speaker.
Yeah, it's just a formal introduction as Dr. Kadam doesn't need any introduction. He is a German neurology. He has done his post-graduation and further practice in that field only. So I'll request Dr. Kadam Nagpal to deliver this talk.
Thank you, sir, for this. And the question comes whether the tremors are Parkinson or not. So my slides will be having a prologue talking about Parkinsonism, Parkinson plus syndromes, whether it's Parkinson's or Parkinson plus, and some clinical tips and tricks. So I'll be just having some kind of videos and which are very clinically based. So they would be very helpful in making some kind of spot diagnosis when the patient arrives at any clinic or any OPD. So it all started with this monograph presented by James Parkinson in 1817, which was a characteristic for shaking palsy. So this is from where the onset of Parkinson or Parkinson disease is started from. So Parkinsonism is basically defined as presence of bradykinesia and at least one of the followings: rest tremors, rigidity, and postural instability. So usually this is the classification which we often follow, which is either it can be a primary or an idiopathic type of a Parkinsonism, or a secondary type. It should be a Parkinson plus syndrome or a heredodegenerative disorder. So just to simplify the classification, this is how we just diagnose and determine. So once we find a patient of Parkinson or Parkinsonism, let's not use the word Parkinson as of now. We'll use the word Parkinsonism. So whenever we find a patient of Parkinsonism, anybody who's got a rigidity, bradykinesia, freezing of gait, some kind of postural instability, we term it as a Parkinsonism. Features are suggestive of that. It could be a primary or it could be a secondary. So anything that is a primary Parkinson is basically an idiopathic Parkinson, prima facie. All other syndromes fall into the category of atypical Parkinsonism. Be it secondary Parkinsonism, which could be a vascular Parkinsonism, it could be a post-encephalitis, a paraneoplastic, or an autoimmune sort of a disorder, or it could be a Parkinson plus syndrome, like we often commonly see, like progressive supranuclear palsy, multiple system atrophy, corticobasal ganglia degeneration, or a different subset, what we call it as heredodegenerative disorders, which could be like Wilson disease, spinocerebellar ataxias, neuroacanthocytosis, and Fragile X syndromes. So first of all, predominantly, let's first of all, whenever we find a patient of Parkinsonism, we often ask for the history. If it is an acute or a subacute onset, always look for the drug-induced Parkinsonism. So if we see the first video, we see a characteristic hair lip or a rabbit tremor. So this is basically a patient of drug-induced Parkinsonism. Often medications like antipsychotic, antidepressants used injudiciously. A commonly used medication like levosulpiride can bring about these kind of side effects. So second patient, we see the orofacial dyskinesias. So this is predominantly suggestive that the patient might be, it's a telltale sign of a drug-induced Parkinsonism. We just go for the history and we often look into the drug formulary, what exactly the patients might be having. So this was a lady with Parkinsonism having predominantly orofacial movements. So Parkinson plus syndrome, what exactly it is? So it's often been defined into it's been just like sub-delineated in various categories where the disorders are progressive supranuclear palsy, multiple system atrophy, dementia with Lewy body and corticobasal ganglia degeneration. So first four are very important because they are diagnosed in a clinical setting, in an OPD setting rather. So once the presence of Parkinsonism has been established, the main question is whether the patient has a Parkinson disease or an atypical Parkinson disease. So this is where we differentiate whether the patient is having an idiopathic Parkinson or the atypical Parkinsonism. So atypical Parkinsonism encompasses, as mentioned, progressive supranuclear palsy, multiple system atrophy, dementia with Lewy body, and corticobasal ganglia degeneration. So starting from the idiopathic Parkinson disease, very characteristic. So we see this lady, right? We see bradykinesia on the left side, right? The left-sided movements are very slowed. We see definite some kind of cogwheel sort of a rigidity in our movements on the left side. The right side is absolutely fine. So for idiopathic Parkinson disease, it should be asymmetric predominantly. It can be symmetrical in the later part of the disease, but to start with, the disease is often and mostly asymmetric. So we often are being trained to see the asymmetry in patients of Parkinson and Parkinsonism. Look for the rest tremors. Look for the cogwheel and the lead pipe sort of a rigidity. Lead pipe rigidity often occurs later in the course, but cogwheel rigidity is something which is being caught up in early and incipient stages. Look for the asymmetry. Always look for the asymmetry. We see for the rest tremors, right? Very, very fine rest tremors, 4 to 6 hertz, right? That are visible once the patient is being often relaxed. So we often just ask the patient to just put the hands onto the lap and just relax for the clinical examination, and then the rest tremor appears. Because whenever the patients are disturbed or in some kind of a posture, the rest tremors is often not apparently visualized. Then we look for the hypomimemic phase. So hypomimemic phase is basically masking of facial features which happens. So the patient does not show any kind of facial expression predominantly. The speech is very hypophonic, very low pitch, low volume sort of a speech is being often seen, and often there is some kind of stuttering or festinating sort of a speech which is often being heard of. And then there is gait with asymmetrical reduced arm swing. So this is what is reduced arm swing. We ask the patient to walk for a clinical examination, and very easily we can see the arm swing on the left side being significantly affected. So the UK Parkinson's Disease Society Brain Bank clinical diagnostic criteria involve that any Parkinsonian syndrome, look for bradykinesia, look for rigidity, rest tremors, and postural instability. Exclude the other diagnosis. And at least 3 of the supportive criteria should be present. It should be unilateral, it should be the rest tremor should be seen. Progressive disorder, very importantly, sometimes in the initial stages we might not be able to distinguish or differentiate between a typical and an atypical Parkinson disorder. Why? Because there could be a possibility that the spectrum might just unfold in due course of time. And that's when we just administer the patients on medications like levodopa, carbidopa. And we see that 70 to 100% of the patients will respond if they are having Parkinson's disease. So this is how we usually segregate the patient of typical versus atypical. And levodopa response generally happens in a very positive way for 5 to 7 years, and the clinical course of the disease is often beyond 10 years. Exclusion of other criteria. Exclusion criteria involve that other ailments should be excluded. There shouldn't be any history of multiple injuries to the head, any history of encephalitis in the past. Drug-induced history should be ruled out. Patient should not be there on any kind of neurolep. Sustained remission should not be there. Strictly unilateral for more than 3 years is something that has to be looked into. Patients who develop cerebellar signs, patients who develop autonomic features, patients who develop eye signs to start with, they fall into the category of the atypical Parkinsonism. So what are the red flags for the diagnosis of PD? So Parkinson's disease red flags are very important. If there is early or prominent dementia to start with, if the Parkinsonian signs are symmetrical at the onset, if there is bulbar dysfunction, if there is a gait disorder where there are early falls into the ailment, and patients become wheelchair dependent within 5 years of the ailment, sleep apnea, apraxia, alien limb phenomena, then there is a high likelihood that we are not dealing with Parkinson's disease anymore. We are looking for the atypical category. So to start with, Parkinson plus syndrome. Predominantly we see patients with progressive supranuclear palsy. It's a neurodegenerative ailment as we understand. And the average age of onset is 63, and the mean onset from the symptom to death is usually 7 to 8 years. So, this is a characteristic feature of a patient of PSP, right? We see prominent procerus, we call this as omega sign. So, prominent procerus will just have a startle-like face of the patient, and it's just like the patient is in a state of startle, just like eyes fixated towards the examiner. It's a symmetrical and axial Parkinsonism. Postural instability occurs very early. There is supranuclear gaze palsy, usually down gaze paresis occurs earlier into the ailment. Why? Because midbrain controls it. There is pseudobulbar palsy with dysphagia and frontal and subcortical type of dementia seen. So we see that the patient's horizontal gaze is still relatively spared, and simultaneously we see the upward gaze, the vertical gaze, which gets affected. as if eyeballs are like completely fixated. She's not able to traverse. So basically, we see there's a lot of up gaze restriction. So eye signs in progressive supranuclear palsy are very important. So there could be slowing of vertical saccadic movements, downward in particular, supranuclear palsy of vertical gaze is important. There would be a markedly reduced blink rate and closure of eyelids due to eyelid dystonia. So the patients can be presenting with either an oculomotor apraxia, where there would be a difficulty opening the eyelids, or there could be sometimes a blepharospasm where there would be a forceful closure of the eyelids. So we see in this particular patient, he is not able to have a sustained open eyelid. So he's been having an oculomotor apraxia in the background of progressive supranuclear palsy. And with the help of some kind of cues, he's able to just lift up the lids. Another patient we see, he basically he plays tennis rather. He's enjoying his post-retired life, but he's not able to open up the eyes when he's being entering into the court. And he just got to understand that something is wrong with the lids. And then subsequently the falls came into the place. So he was diagnosed with oculomotor apraxia, and we see that with oculomotor apraxia, he's been simultaneously having very forceful eye closures, which is blepharospasm. So in this patient of progressive supranuclear palsy, we saw both oculomotor apraxia as well as blepharospasm. So this is where the forceful eye closure is. So how do we categorically differentiate between a progressive supranuclear and a Parkinson's disease? So postural falls and instability are a hallmark of progressive supranuclear palsy. They are usually not seen in Parkinson's. Pill rolling rest tremor is very categoric of Parkinson's disease. And sometimes the patients might be having some kind of hyperextension or retrocollis posture, which would be seen in Parkinson's disease. Gait is usually broad-based, and freezing of gait is common and may lead to diagnostic confusion with multiple system atrophy. There could be, initially, as I mentioned to start with, there could be a mixed bag sort of a picture where patient would be having some kind of subtle features of almost all the ailment, and gradually as the ailment continues to degenerate and deteriorate, we see a classical spectrum coming into play. So different, it could, progressive supranuclear palsy could be a classical type, or it could be something where there could be pure akinesia or a corticobasal type of a phenomena, or it could be dementia predominant PSP. So basically these are clinical diagnoses. There is no set investigation to it. We diagnose the atypical Parkinsonian features predominantly on a clinical repertoire. So MRI abnormalities are usually midbrain atrophy. We see a very categorically a hummingbird sign in progressive supranuclear palsy, or a morning glory sign. As far as investigations are concerned, there are many investigations which have been taken up. We often get a F-DOPA PET or a TRODAT scan in such patients, but F-DOPA and TRODAT have got some kind of limitation that they don't differentiate well between all the atypical Parkinsonian features, right? So yes, but for a patient who might be having a drug-induced Parkinsonism, a TRODAT scan is something which usually clinches the diagnosis. So the diagnostic, basically, as mentioned in the slide, it could be SPECT or PET, but we usually go by the clinical methodology, because eventually subjecting patients to such expensive investigations would be eventually worthless, because clinically we establish the diagnosis and start the medication and the prognostication of the ailment also. So currently there are no effective symptomatic or neuroprotective treatment for PSP, because it is the midbrain, that is the area which just takes up the hit, which results in a lot of gaze paresis, gait abnormalities, freezing and falls. A trial of levodopa nonetheless should be started in all the patients of atypical Parkinsonism. It is being said often patients do get a 10 to 15% of benefit, and even that's also worthwhile. Botulinum toxin often works very well in such patients, especially those who are having oculomotor apraxia. So we gave this patient to just enjoy his tennis game, some Botox over the eyelids, and he had a remarkable recovery. He's still been playing, let's hope so he does so. Other medications like coenzyme Q, vitamin E, they are all being tested to reduce the oxidative stress over the brain, but methodologies involving physiotherapy, early peg tube insertion, or early tracheostomy are something which have to be considered earlier into the course of the ailment. Similarly, just to skim through, other Parkinson plus syndrome which we often see is a corticobasal ganglia degeneration. Symptoms of Parkinsonism here are basically unilateral. There would be an alien phenomena, there would be dementia. Average symptom from onset to death is basically 8 years. And the striking thing that just like often confuses the clinician is sometimes this type of a atypical Parkinsonian ailment has got a asymmetry to start with. So basically it's strikingly asymmetrical. Alien limb phenomena is often a phenomena that is being seen as a cortical apraxia and cortical sensory loss. Dementia is a very important sign. Episodic memory is often well preserved if we just draw out a comparison with the most common type of dementia, that is Alzheimer's. And patients might be having a frontal executive defect or a parietal lobe dysfunction. As mentioned, there are phenotypes. Sometimes it could be symmetrical, corticobasal ganglia degeneration, often just having a similar sort of a phenotype with Alzheimer's. So MRI usually just shows some kind of stark asymmetry. So we see there is a lot of atrophy on the left side. There is a left parietal area which is atrophied in this particular scan, which is suggestive of asymmetrical involvement to start with. The treatment options are often limited to levodopa. We give valproate and levetiracetam to reduce the myoclonus. Botulinum toxin often alleviates the dystonic spasms. Early management of dysphagia is very important. Walking aids and wheelchair might just prevent the falls. Then we have commonly seen like multiple system atrophy, where Parkinsonism would be symmetrical, but simultaneously there would be autonomic features, there would be cerebellar signs that would predominate this particular clinical finding. And the classical asymmetrical pill rolling tremor is often not seen in multiple system atrophy. So these are the videos, right? So we see the patients often come with a gait deformity. There would be a stoop posture, there would be significant anteroflexion, as in this particular patient we have. And some patients might be just like showing lateral flexion, which is often we often call it as Isa sign. So atypical Parkinsonism often presents with a characteristic deformity, what we call it as parietal hand deformity, where there is some kind of flexion in the metacarpopharyngeal and there could be flexion or extension in the interpharyngeal joints. And we see polymini myoclonus in this particular patient, where there is some jerky movements resulting in some kind of joint movement. And we see apraxic gait disorder. So apraxic gait disorder, there is some kind of gait initiation failure. So we see the patient is having some walking difficulty to start with. So there is an ignition failure, and the ignition failure often gets improved once we give some kind of cues to the patient. So we will put a hammer right in front of the patient and he is able to propel himself further. He is able to walk, he is able to turn. We see a lot of postural instability in this case. He turns and he freezes again. He freezes and then there is again a gait initiation failure. Then we put a hammer right in front of him and he is able to propel himself. Diagnostic approaches altogether. So the clinical features that do not support the diagnosis of MSA could be early dementia, hallucinations, early slowness of saccades, significant neuropathy, age of onset greater than 75 years, prominent and early dementia. Investigation, we often ask the patient to go for an MRI, then subsequently autonomic function tests, which are often helpful, and a nerve conduction study just to rule out the neuropathy. The diagnostic features often seen in multiple system atrophy, although in our clinical setup we often see a hot cross bun sign, which is characteristic of MSA in just 20 to 25% of the cases. So the treatment of multiple system atrophies is symptomatic. Levodopa, carbidopa should be given, and then measures to reduce autonomic dysfunction, fluorocortisone, midodrine. For urinary dysfunction, we give tolterodine, capsaicin, darifenacin. For erectile dysfunction, we give sildenafil, tadalafil. So altogether, the clinical features as distinguished for a typical and atypical Parkinsonism. For a Parkinson disease, it's a pill rolling tremor, asymmetry at the onset. For a multi-system atrophy, it's a symmetrical disease with predominantly autonomic dysfunction and pyramidal sign. For a PSP, it's basically the eye sign, and for a corticobasal ganglia degeneration and alien limb phenomena, myoclonus, and early dementia. So this is the second last slide. I won't be taking much of time. So for Parkinson disease, these are the PET-CT findings what we often see. So basically there is a degeneration predominantly in the basal ganglia and substantia nigra. For a multi-system atrophy, the degeneration is predominantly widespread, symmetrical. For a PSP, we see the low FDG uptake predominantly in the midbrain and the brainstem region. For corticobasal ganglia degeneration, it's often an asymmetry where we see that one part of the brain is not been taking up the FDG at all. And for a dementia with Lewy body, we see that there is a lack of uptake predominantly in the parieto-occipital areas. So, as Singh sir mentioned, diligence and perseveration. So, clinical examination and history taking are very important. For first, we might just miss a couple of signs in the first clinical examination, but we need to keep on examining the patient because the telltale signs might come later into the ailment. And if any of the red flag signs present, think of atypical Parkinsonism or Parkinson plus syndrome. Review the history, look for the face, stance, and the gait and the posture, and look into the eyes of the patient. Eyes tell a lot. Listen to the speech, inquire about the swallowing difficulty, observe the tremor well, axial rigidity, and special features like myoclonus, alien hand syndrome, hand dystonia, or a cortical sensory loss might just point to a different diagnosis altogether. Thank you. Thanks, sir.
Thank you.
एक मिनट ठीक सर थैंक यू
Now I request our speaker.
Respect our speaker to felicitate Dr. Pradeep Jain Sahab. Request to kindly felicitate Dr. D.S. Gupta Sahab. He is such a wonderful talk. And the next speaker, oncologist in Max Hospital, Patna, New Delhi.